Welcome. Good afternoon. I'm Matthew Holt. It is Thursday at just a little after 1 o'clock, episode 86 of THCB Gang. We have a fine lineup of regulars today and one very special guest. So who we got? Michael Millenson, Health Quality Advisors in Chicago. Casey Quinlan, host of Healthcare's Hilarious podcast in Richmond, Virginia. Kim Bellard, THCB regular contributor from Cincinnati. Mike Magee, medical historian, late of hanging out in Mexico and just making it back to the US from Connecticut. And our special guest today is Ines Maria Vigel from Clarify Health Solutions. All right, and she's also the author of the last year's book and textbook called Population Health Analytics, a topic she has been buried deep in for many years. Hi, everybody. Good to see you all. Let's kick off. We'll, as we normally do, we'll do a quick go around the horn of what people have been looking at, and then we'll dive into Ines's career, her special topic, and figure out a bit more about her. So let's start with what you've been looking at, and I'll start with you, Kim.
I've been thinking about gender a little bit. So we have a U.S. senator asking a Supreme Court nominee to define what a woman was so she could make some political points. We have the governor of Florida declaring that a woman a Florida resident who finished second in an NCAA championship to a transgender athlete was in fact the winner. And on the other side, we have two Republican governors banning transgender athletics bills. The governor of Utah is saying that I want them to live, which is a startlingly refreshing attitude from a Republican Party these days. So lots going on with gender, but not much that's good.
You know, bizarrely, yesterday I found out that one of my daughter's classmates, she's only 10 years old, is now referred to as referring to, I guess, herself as, or previously to themselves as they, using the plural. And I was trying to ask questions, so my daughter told me to shut up and stop being stupid. I was like, no, she's them, she's they, and them, and that's it. So, Michael.
Yeah, I'm been focused, maybe Ines is going to solve my problem on the issue of trust. Remember, a couple of weeks ago, we talked about how one of the major functions of these healthcare relationships must be to process fear and worry. Now, my major focus for the last week or so has been in how do you provide trust? And what's caused me to do that is that I've been dipping in and out of long-term care, which I seem to do quite often. The two specific areas that I've been dipping into this past week are, number one, the variations in workforce quality in long-term care institutions, which creates groups of family and loved one who don't feel they can trust the people that they're paying to take care of their loved one. And the second area is the area of early cognitive decline, where an individual who has a family history of Alzheimer's begins to feel like they may be the next in line because they've noticed some things are going wrong and they can't quite be sure whether they're depressed or whether they're having issues with their spouse, but they have a sneaking feeling that it may be Alzheimer's, but they can't find soon enough somebody to evaluate them. They can get an appointment in 8 months at one of these fine integrative centers, but by the time that they get to that, they'll be already crazy. So that's what I've been focusing on. How can you, with or without technology, improve the amount of trust in the system?
Yeah, that's interesting. There's a couple of startups that have been sort of trying to do the tracking of cognitive decline, because there's a massive bottleneck in trying to get to the right specialists in there, as in many other areas. All right, Casey.
Well, I'm going to kind of do a quick mashup of, I keep saying that the U.S. healthcare system is going to have to collapse in on itself before it actually changes in any noticeable way to the benefit of actual users and the people who work in it. The Service Employees International Union, the local, which is very large and very powerful in the New York metro region, has stood up and said, no, we're not happy with any of the rates that we're being offered by any of the insurers that we're working with. So we're going to use our purchaser power to press for more equitable billing and, reimbursement rates. So there's the power of labor organizing and purchasing power in healthcare happening now. This is a new story that's just happened. This just broke this week. So stay tuned for updates. Now, simultaneous with that, there's been a long conversation going on in the patient community over a very clickbaity headline, which I can't really refer to right now fully, but it did contain the word overblown about what patient expectations were about healthcare, telehealth being overblown. Those pesky patients, they want to have convenience, the NOID. And, I think that some of that was clickbaity, but I also think that there are a loud, if minority, population of people, both on the payer side and the provider side, who aren't into this whole let's change healthcare and make it more convenient for patients thing. And then a very interesting article in Retraction Watch about the publishing of the study behind Aduhelm to, sort of go off of both the, early Alzheimer's thing and the long-term care thing. If I just encourage everyone to go over to Retraction Watch and look at that article. It is hilarious. And, why Biogen thought that no one would notice that this was not a top tier journal that this was published in is like, I'm sorry, what? So, yeah. And then I just, speaking of wages and justice and people and money, the minimum wage in this country is still $7.25, where it has been since 2009. And if, anyone who's ever dealt with nursing homes knows that the people who work in nursing homes, the ones that bathe you and tend to you, and I mean, really, you rely on them for your lives, are typically paid pretty close to minimum wage. A lot of them are only making $7.25 an hour. So your mileage may vary in healthcare in the United States, just like, with everything else in long-term care as well. And it can get ugly.
All great points.
Mic drop. I don't know. Everybody shut up. What happened? Did Mike's broken?
Not quite. Michael, other Michael.
It's their fault I didn't go into private equity.
That's going to be rescued by the Quitam suits, according to stats.
A few things. So first of all, just in brief on the issue of transgender, Kim, I was sent by a tabloid type editor back when I was a journalist in 1989 to interview a male who was going through sex change surgery to become a female and couldn't get insurance to pay for the coup de grace. And back then they were called transsexuals. And back then my reaction was, what? Yuck, you're asking me to do what? But from talking to this individual, despite the assumptions that I went in with, which is probably in 1989 what your average Republican senator has today, is that it was really real for a lot of reasons. A couple of things. I was at the Leapfrog Gala last week, which was the 2-year delay of the 20th anniversary. And I was actually, when they were launched, I was working at Mercer and helping the founding frogs who launched it. And I have to say, as positive as it was to be around people who are still promoting patient safety, when you step back and look at what's happened and what hasn't happened, I wrote an article in 2003 called The Silence about how it's not talked about much and then nothing is done and how many millions of people have died. And there was an article in New England Journal a few weeks ago that we backslid. But if you even look at the Leapfrog group, they were founded on the proposition that the payers would force patient safety onto the providers. It was in the year 2000 after the IOM, and all those big corporations that were behind it, none of them were sponsors of this group. None of them were really still involved. Some of the individuals who worked there were involved still, but when the individuals who cared about patient safety left, the interest went away from large corporate purchasers. Even though I used to say to the HR managers, I said, look, if you could choose which employees were killed, you might increase your productivity, but you can't do that. So you might as well try to prevent deaths and disabilities for all of them. For some reason that didn't work. And on the same realm, the providers, the people who got the Lifetime Achievement Award, well, one of them was Gary Kaplan at Virginia Mason, who's been there for 22 years. And again, we have a case where the institutions that go to zero harm, when the person who's promoting it leaves, they all backslide. And if you put that in perspective, nobody ever says, you know what, the chief medical officer turned over, so we don't wear masks or gowns anymore when we do surgery, because what the heck? Right? I mean, we don't turn over some things. Why do we still turn over some of the other things like preventing infections? But, again, we haven't got there. Finally, in a note about a lack of common sense, I heard today that by failing to approve the money for the COVID extra appropriations in Congress, we've already started to cut things like testing people for COVID who are uninsured. Because after all,
and treatment.
Why would someone who's uninsured ever pass COVID on to someone who is insured? Really, because there's a blood-brain barrier mostly between the brain and the people doing this. And again, you just sort of wonder. And for me, I look at tribalism. Right? It should be that the tribe of doctors, the AMA, says to the tribe of doctors who are Republicans and other else, look, this is not a partisan issue. This is a public health issue. It's not even a freedom of choice issue like wearing a mask. This is just common sense. But it turns out that politics, we're afraid of you, is stronger than the so-called professionalism and tribalism. And it's just a shame. So just make sure as you take off your mask that you ask the person next to you to show you their insurance card.
It'll work out fine. All right. My quick comment on that one is that we've got, there was a great article in Stat from Bob Herman about PBMs this week, which noted that the guy who had gone around essentially, helping employers get better deals out of their PBMs got himself fired, so much out of business because he upset the employers too much because he was making their lives difficult. Also, they were a bit worried that they might show to their bosses as not having done a great job over the years. So, I mean, it's the same stuff we've been talking about, lost in the weeds. All right. And Ed, just to introduce you a little bit to the crowd, you have, since you did medical school way back when and did residency at Hopkins, you have been in population health and primary care ever since in a variety of places. I mean, I'll get it wrong, but at Hopkins itself, at Healthwise, at I'm not going to cheat by looking at your Priority Health in Michigan, and also at Blue Cross Blue Shield of the capital area, right? No, Maryland. Forget it right. Bunch of places. And now you're at Clarify Health, which is one of these, for those who don't know, one of these venture-backed analytics companies that does a lot of fun stuff with data. So could you just tell us a little bit, just to start off with, a bit about your, and it doesn't have to reference back to what we just heard, a bit about your sort of philosophy of what population health is? Because it seems to me, if you pick up on what Michael just said about patient safety, it's been one of these things that, in fact, Michael wrote a book about it. Not so well, a long time ago, I want to say now, Demanding Medical Excellence. But it's been one of these things where we've been talking about it for a long time. We should be doing it, and no one quite understands how to get it done, or actually what it is. So why don't you tell us what you've been up to for your career?
Well, I'll tell you, I still get the question from my parents to just give them the one sentence that they can tell their neighbors of what it is that I do. So I'm not sure I've succeeded in being able to do
don't worry about that
yet. But essentially it means I'm a doctor who doesn't see patients, who works on the administrative and system sides of medicine as an epidemiologist, who looks and uses data to help answer some of healthcare's most challenging questions. I've been doing that for 16 years. I actually got started working with the Indian Health Service, and I worked with the team that helped to allocate the funding of IHS, utilizing biostatistics and epidemiology. And then I went to medical school thinking everybody used data to allocate healthcare dollars, and learned very, very soon that nobody used data to equitably and affordably allocate the healthcare dollars. And so I became fascinated in the world of fee-for-service, insurance, and how the healthcare dollars allocated. And so I fell into being a doctor for that reason, fell into working with data to solve for that question. And then, for fun, went and got my MBA, went to night school and got my MBA in healthcare finance, just so I could understand how the dollar in healthcare works and is spent. So when somebody says, what is population health? I would definitely say it is a multidisciplinary application of concepts, theories, and frameworks that allow for populations to be, and their health needs to be assessed, understood, for clinicians and business leaders and analysts to work together to identify what interventions might be possible and actionable within that population, and then tracking and monitoring those interventions as they're applied over time to determine what effect, if any, did they have on the population being served. How that's different from public health, because that's always the number one question that I get is like, why is that different from public health? It's not. Public health is one of the disciplines that's used in population health. And population health really is focused for health systems to be able to use it and apply it in real world settings, in real world time on patients across the US within the boundaries of fee-for-service, value-based care arrangements, and other forms of payment. So I hope that's the long answer, not a sentence that my parents would love or appreciate hearing, or maybe even understand.
Well, my father figured out eventually what he did. He was a surgeon in the UK, and he eventually figured out that I wasn't a doctor. I was working in healthcare. So he said, you must be a hospital administrator, which he regarded as the lowest form of humanity. So he can't get with me pretty quickly. But let me dig in a bit. Now, you wrote a book last year, or you co-authored a book on population health analytics. Oh, look at that. You've been taught well by your press team. And,
I am my press team, just so you know.
Fantastic. But tell me a little bit about the analytics part of it and how that's changed. And you've worked with a lot of provider and payer organizations, and we'll dig into in the rest of the whole session about how impactful population health has been as a movement. But I mean, how you've written about analytics, and you're working for an analytics company now, not for somebody who's actually doing the stuff. So tell me a bit about that's a bit about the one. Not that it's not important to have analysis, but a company which brings its tools to other people to other companies to do stuff rather than does it directly itself. So tell us a bit about both the book and your role at Clarify.
Yeah, I'll tell you the story of the book and how it came to be, because it tells a lot about how in the world would somebody like me spend 9 months of their life just trying to, getting up at 4:30 in the morning and writing every day and trying, what is it that I want to send as a message with my co-author, Dr. Martha Sylvia. I would say I did not write this alone. My co-author is Dr. Martha Sylvia, who is like me, has been working in this industry of population health, value-based care, transforming healthcare systems from fee-for-service to value-based arrangements for 16 plus years. And it's unfortunate that in order to be properly trained in all of the facets of healthcare, that I had to go get 3 degrees to do it. And it really does take my 3 degrees to understand each component and aspect of it. And I only scratched the surface of really understanding what and how we can make a difference as providers. I am a clinician myself. I practiced for a long time, and I was, understanding how disparate how healthcare is paid for and how wide the street was to how healthcare is delivered, and how wide that street is to then what's the effectiveness that we're achieving as a result of all of those activities. And really wanted to be able to bring and bridge those together in a way that makes sense for folks that use this. And so the analytics side is just that. It is kind of, not just standing there on the top of my podium and saying, hey, we should do this, or you should do this, or this is the right way to do something, but, having some charts and graphs to back it up and understanding what the patient needs actually are, and then working with health systems to convince them that what they think they're providing may or may not actually address the health challenges that their populations face or have or are expected to have. So a lot of data can really just be used in healthcare to forecast what might be happening or what might be in the future of an individual healthcare organization, where to allocate their resources and services, particularly when they're scarce. And I want to bring this back a little bit to something that was said earlier in terms of, I'm really concerned in healthcare about this healthcare workforce burnout that we're seeing as a result of the pandemic in frontline care workers across the country. Never before have I had so many ER physicians call me up and say, what is it that you do? You're an administrator? How can I be one? I'm tired of working at the ED. If I have to intubate one more person that didn't get immunized, I'm going to break. And how that plays out into the scarcity of workers, the quality, as was raised by Mike, the quality of the healthcare workforce out there. And if we really knew how impactful each of the roles were in our healthcare workforce, would we really only pay them minimum wage? Or would home healthcare workers hold a statistical significance that's higher in the contribution to a person's health, and therefore we can value them differently, pay them differently, and they end up being the most highly paid healthcare workers in the industry, right? So you can use, and I have used data to kind of tell these stories to healthcare executives on the health plan side, on the health administration side, on the provider side, to convince clinicians that maybe, even though clinical evidence base is there and they can use it, that there's also this context that we live in called society that we have to account for when we're treating patients. And I think data can do that in a really good way. So what we were trying to do with the textbook, because this is what we found, my colleague and I, is that we'd go into organizations and work with them on the front lines, and we'd say, okay, what does population health mean to you? 200 different responses. Well, what do you need to do population health? I don't know. Well, what do you have to do population health? 20 different tools, not enough tools, a technology platform, no platform, a data warehouse, no warehouse, data, no data, awareness, no awareness, interest, maybe, maybe not. We'll try it, but we'll be quick to remove ourselves from it, right? It spans the gamut as to what the definitions are, how do people use it, what are good examples and real world examples of how you can apply it in real world settings. And so my co-author and I just really tried to educate folks with a standard reference tool that they could use to stimulate a common language that can be spoken around what it is, how it works, and how it can be applied.
So let's dive into that. But just before we do that, I do want to know a bit about Clarify and why you're a Clarify, because it's compared to, a plan, a provider organization, whatever. Other than they're flush with venture capital money and John Druin's a good looking guy, there must be some other reason you signed up.
I'll tell you, I found Clarify. Clarify did not find me. I've spent 10 years of my career going into healthcare organizations one by one and doing everything from helping them architect their data sets to rolling up my sleeves and working with the clinicians side by side to translate the data into action. Now, what I've learned over my career is that every healthcare organization is trying to do it themselves, and they're doing it horribly. They're spending way too much money and way too much time on trying to architect these solutions from scratch on systems that aren't even built or capable of doing it. And they're hobbling together 25 different tools to do it. So by the time they get to actually doing population health, which is the harder part, is the operations part, by the time they get to that, they've already created such a huge bill that there's no way they can possibly get an ROI anymore. And so I did this for organizations. I would go in and I would architect these data sets and I would get results, and they were real results, but it was impossible to overcome the already misspent money and funds that they'd spent on architecture, infrastructure, and a data set. So when I was doing research for the book, I bumped into Clarify and I saw that one, they had an outside-in data set that was already cleaned and governed. They had a technology platform that sat on top of that made data rendered for analytic use within seconds and minutes. What used to take me 3 months working with an analyst side by side, now I can do in minutes. And it has an analytic layer that means I can just query it, as I don't have to have 3 degrees and 16 years of experience to be able to use it. And so I actually raised my hand. I had been working with the product team, just kind of doing some consulting with them. And I raised my hand to our CEO and said, hey, you're putting me out of business. Like, I don't want to do the job I used to do anymore of going into these health systems and helping them figure it out and working with inadequate, improper tools, no budget, and creating these ROIs that were unachievable. I'd rather just tell them to buy this and get to doing the work, the hard stuff of drawing the insights, working with the clinical teams or non-clinical teams to apply the interventions and get to the results much faster, much more effectively, and much more accurately than hobbling it together myself. So Clarify kind of replaced me. So I kind of raised my hand and asked if I could work there.
They're about to put you out of a job, so you might as well go work there. But I mean, essentially, they can take their normalized data set and then go to a hospital or a health system or a plan or whatever, and match it to the actual data set of the incumbents. Is that right?
That's right. If it's your patient and you're part of the care team, and you would normally have access to their individual patient level detail of data, then yes, you qualify to have that. If you don't, you can see a de-identified version at the 30,000 foot view that allows you to see the trends, the opportunities, the details of quality, cost, and utilization, and not have access to the level of patient level detail to protect.
So just before we get to you, Michael, so they are going and sorting that part, sorting that part out. I think most of the conversation we're going to have for the rest of this is about how far this is going and how far it's working, whether it's going to work. But what are the what's the low hanging fruit? What are the, now you've got the fine data set, you walked into somebody who wants to do whatever population health is or what they think it is. You tell them what it is, you bring them the data now. What are the sort of 3 things that they do, the 2 to 3 things that they do that actually can move the needle on impacting health? What are we missing? What should we be doing in this country?
Yeah, so one of the biggest things that I always say to organizations that I've worked with, and just so you know, my role at Clarify is the Senior Vice President of Provider Solutions, and I work also as an interim transformation team leader. So I'm actually working with customers. That's my role. Work with customers every day to use this stuff and apply it in real world settings. And one of the things that I most commonly ask them is, do you understand or have an assessment of who your population is that you're serving or that you will be serving within the next 10 years? And that really requires a community kind of population health assessment. And what I love to do with organizations is, once that's completed, if they have one in place or if they're able to do one, and they can with the clarified data set, they then have them compare that to where their strategies are, where their money is, because I follow the dollars. That's how I can tell how serious a healthcare organization is and what they're doing, how they're achieving their results and what they're focusing on, and whether or not they're doing too much, meaning like dipping their toe in the water of 20 or 80 or 100 different initiatives, but never really committing to any one of them. And then once that assessment to their population can be done, you can start to do that gap analysis of, is what the population needs, where across your organization are you able to serve that up to them? And how good are you at doing that? Where are you excellent? Where do you need improvement? And where is there opportunity? And then how much time do you think you'd like to take to close that gap on any one of the areas that you've identified in the assessment itself? I think even just that strategic level of thinking, utilizing the data and thinking more broadly than what you do every day in terms of service line and widgets and units, helps organizations to really think through and set their strategic priorities and the funding for those strategic priorities differently. And one example of that is helping, we were really interested in one of the payers that I worked with to take on value-based care. They were integrated health and care delivery system, meaning they are a provider of care and have a health insurance company arm. So they're financially invested for their employee population to not only cover their employees with the breadth and depth of health insurance services, but also deliver excellent care to those employees to ensure highest productivity, less absenteeism, and just overall employer-employee satisfaction and satisfaction with their healthcare. We were able to architect not a 5% of my financial dollars, not 50%, but a 100% downside risk arrangement, where the dollars would flow to the healthcare delivery system should they manage the care efficiently and effectively and raise the quality of care at the same time as monitoring the dollar and ensuring that the dollar was not increasing past, financial targets set by the payer. We were able to then identify in the population where opportunities existed to intervene. We worked with a cardiology group who identified a couple thousand patients who were repeatedly going in and out of ED and inpatient admissions and were readmitting with their chronic heart conditions. And we were able to work with them to get their readmissions and avoidable inpatient admissions from almost 76% down to zero for more than a year. And that was one of multiple initiatives on the risk-based contract that at the end of the year, we quantified, and there was a significant transfer of that premium dollar from the payer to the care delivery system because they had not only managed the care, but also improved the quality over time for those different patient sets that were identified. And we were able to track and monitor all of that to show that the success was there. Had those patients continued through the existing system that they were navigating, they would have continued to see the results that they were getting, which is really significant admissions, readmissions, and decreased quality of life for those patients as well, just because they're in and out of hospitals, in and out of home and healthcare services, and absent from work.
Absolutely. Michael.
Inez, if you're merely able to get 100% risk to all of America's doctors, I believe provider transformation will follow.
You like following the dollar too? You like following the dollar like I like following the dollar.
I used to say, so I wrote a book about medicine, the information age back in 1997. And one of the inspirations, and I couldn't use that kind of sentence with the lay public, but Yale's epidemiologist, Alvin Feinstein, talked about continuous epidemiology. And that essentially is what quality improvement is a continuous epidemiology, like you talked about real time with real people. Except if you say things like continuous epidemiology, you will never be published by a normal publisher. So I tried not to use that term. In fact, they would not even let me use the word healthcare in the title because that's boring. Also, you have to say medicine.
Matthew would publish you if you said healthcare is 2 words.
Absolutely.
Michael's
on my side there. He's written the piece like quite about.
I've been an advocate.
Let's not go turn on that rabbit hole.
a losing battle, but so what Clarify does is really interesting. One of the things, and I had a couple of questions. One of the things when I look at the companies that are doing these algorithms, you guys or Carrot Health and some of the others, I have not seen anything that compares. First of all, I see nothing in the peer-reviewed literature about how this stuff works or whether it works. Yeah, now people are paying you money, so that's an indication that it works, and everybody's got anecdotes, but I've seen nothing in the peer-reviewed literature. And then the second thing is that it can't be where everybody is excellent. Everybody is equally excellent, but some of them are more excellent than others. And really, I've never seen any comparison among the different algorithms of the different companies doing it. And now you have, Deloitte has something they put in. And so have you done any sort of, private stuff that would be published in the literature? Has anybody compared the algorithms? And then finally, I don't think patients know that this stuff even exists. And I know you worked for some great organizations before this, and I'm sort of wondering, what you would say is for the peer-reviewed literature, the comparison, and the patient disclosure.
Yeah, there's a lot in there to unpack, Michael. But I think just to start, there is a foundation of clinical evidence base and statistical basis that is in the published literature that a lot of companies use and is pretty robust, like observed to expected, standard deviations from the mean, a lot of the data science that's rooted under some, but not all of these tools. I know Clarify uses them because I really learned a lot about that before I joined. and really understanding how benchmarking comparisons can be made really depends very highly on how you're categorizing clinicians, because clinicians aren't generalists anymore. In fact, specialists subspecialize. And you have your hand surgeon, and you have your hip surgeon, and you have your primary care physician that works primarily with as a geriatrician with older age populations. You have pediatricians who specialize in cardiology or orthopedics, right? So how do you start to get to defining who the clinician is? What are the breadth and depth of services that they provide? If it is procedure-based, that those procedures are compared like to like, so that you really can truly compare populations and of patients that they're serving, and you can compare the clinicians against a set of benchmarks for a given set of outcomes that you want to achieve. That's the first thing. The second is all of that has to be completely transparent. The calculations, the definitions, the way that somebody is categorized, what their services are that they're providing and how they're compared, and it has to be relevant to the populations that you're serving. So there are good parts about using claims-based data, because you can get trends and cost data, and you can get statistical significance in ways that you can't get when you're looking at same-day EMR admits and transfer and discharge data. There are certain ways that you can use EMR data that are more timely than what you can use claims data for. So I think the third thing to say about that is you have to, I believe very much in use case-based population health and value-based care. Don't just look at the data to look at the data. Identify what it is that either your population needs, what they will need, or what you do really well. And then look for those patients that you would best serve, and hone in and focus on a core set of activities or initiatives that you want to be successful and can be successful in. And then go get it, go deep, go 100% downside on it. Like, don't just dip your toe in. If you think you're the best, then be the best and write everything down. As to your question about, there are a lot of companies out there, and it's really sexy to have a bunch of algorithms right now. It's really sexy to say that you do artificial intelligence, machine learning. I'll tell you a story that I told recently at Vive, which Matthew maybe saw my talk in, which is, I think I was doing machine learning and artificial intelligence like 10, 15 years ago, but it wasn't the sexy term. And I was in a basement with no windows and a bunch of, analysts with me doing it together, like a economist, an analyst, a clinician, kind of doing that work together, writing algorithms. And whereas those algorithms allow you to focus in on populations for certain aspects of care that can be delivered really well, machine learning can identify where, what is the signal and how statistically significant is that signal and how important should you weight it in your decision-making. It still needs to have context by the clinician that is delivering the care. They still have to think about whether or not that patient is the right patient, what outcome you're trying to achieve, and how to track and monitor that patient's progress so that you know that you've gotten there when you get there. You cannot do that if you don't know what the risk factors are that the algorithm identified, who and what statistical significance each of those unique characteristics bring forward, and what the dang calculation is that's being used to calculate their risk score, right? So it's really hard when a company says, oh, we predict risk. What does that even mean? I'd rather a company come and tell me, there is no risk score. Here are all the factors of an individual that contribute to their risk profile. And here are how they are weighted differently so that you can think about which one your intervention is really going to solve for and what underlying cause is driving to that particular risk profile in that patient. And what that means is you actually have to talk to the patient. You actually have to figure out what they're doing. You have to confirm all of this data that you receive, because these are just signals, if you will. You still have to talk to the patient to see, for example, we have data on social determinants of health that says whether or not you live in a high crime neighborhood or not, or even better, whether or not you have or don't have transportation.
Right.
Well, living in a high crime neighborhood, I live in downtown in a city that could be considered high crime, but I don't think in my mind, I don't think that's a social determinant that's affecting my health personally, right? So that's a factor that needs to be validated. Transportation, I may not have transportation, but I may live in New York City with a great subway system. Who uses who has a car in New York City? You're driving that around trying to find a parking for an hour if you do. Those are kind of like signals that you still have to validate and verify with patients as you use them.
And I agree that this whole your zip code destiny is sort of silly if you live in cities where things vary and the neighborhoods are changing and all the rest of it. We can have another discussion, but it's interesting because I think there's been a lot of oversimplification and a lot of, and I talked to Gene some years ago and he was not that, but there's a lot of, we're delivering magic.
Casey.
Well, I'm going to kind of go. I recognize that what Ines is delivering, and not just her, but the company that she works for. But I recognize that this is delivering this particular set of services to a specific group as opposed to across the entire system. I see that there could be some benefit to the idea that standardization of the system around the discoveries that are made by the work that they're doing could be a great leap in the right direction. Stay tuned for updates. But because I live in the real world, my challenge is always like, okay, but how do we get past the fact that a lot of the data that winds up in these systems is crap, some of which has to do with your zip code determines your health stuff that was just discussed, which is a little bit more predictive in rural areas than it is in cities, but be that as it may. But COVID is a perfect window into how bad our data
infrastructure
housekeeping is when it comes to, whether or not, we don't even really know how many COVID infections and deaths there have really been. It's an extrapolation based on, I don't know, a little bit of data science and throwing the I Ching to figure out how many people actually got COVID and how many people actually died from it. Because state by state, and this is a global problem, it's not just in the US, but it's really visible here because we spend $4 trillion a year on healthcare and we're still trying to find our butts with two hands and a map. But I don't, what Ines is working on is a really good idea, but most of the system is still so disconnected. Even if she got a chance and, whatever the name of the company is, it fell out of my head. I'm an old lady with cancer. So, sometimes stuff falls out. I'm sorry if you saw that, but anyway, it just, I don't see that accelerating the rapid change we need to not end up going down the sewer. And a lot of the data, again, that ends up in population health scoring is stuff that the end user or the creator, and then the end user whose underwear is being sniffed by surveillance capitalism doesn't even really know what data about them is really visible to even their insurers, and their employers, because, if we're all walking around with these suckers, these are snitches like, the Stasi wish they could have known,
the Chinese have got that covered now.
Google, Apple about me based on my activity with my phone. But it's just, I'm still waiting for, actual improvement that can be delivered quickly without being creepy. And also using data that's been validated somehow, as opposed to, well, we bought the data from X, Y, and Z, and we got it from quintiles or whatever they're calling themselves this week. And it's like, no, I'm sorry, is that really vetted data, or is that just a really big data set that you paid a lot of money for?
So let's have Anna's defend herself against that before Kim and I dive in on whether this stuff is going to make any
Oh,
difference.
no, and I mean, this was not aimed at the problem.
I understand
But
that,
it is the case, right? Because
Yeah.
if you look at the
You
data
got some
sets
good
that Clarify
points.
others have got, they are coming from sources like that. So say more.
Yeah, it's so I can simplify it really by saying like crawl, walk, run, right? Whereas there's still so many organizations in healthcare today that are doing exactly what you just described, which is hobbling together data sets in an inconsistent way, using them to derive insights that may have meaning, may not, and may be right half of the time or more. And it doesn't feel good as a patient or for a provider, any kind of clinician, if it's on the not so good side, right? If the algorithm gets it wrong, or it doesn't, or it offends you, or it doesn't, identify the right factors that you then self-identify into, right, as a patient. And I think we're not there yet in terms of being able to remove the critical thinking that needs to be applied to data when it's used in any setting, healthcare or otherwise, banking, financial, societal, right? Type of use of data has to be responsible. And I think you're absolutely right. I think for any healthcare organization out there, if you're not asking of your tools, one, how broad do you go? How deep is the data that you have? What are the scientific principles that you're applying to that data that make it relevant, consistent, and useful? And then what's the use cases that they're applied to? And are you using the right methods to apply to that use case such that you're getting a greater accuracy when you're creating a statistic, whether it be a risk score or an outcome score or anything? And then the clinician still has to take that in and understand the context within what the patient is experiencing and living and breathing in, and decide whether or not to use that information or not. What I can tell you is, being a clinician myself, there was a study in Harvard in 2017 that looked at what the half-life is of a graduating clinician in their field, of the knowledge that they know. Like, what's the half-life? At what point in time after they graduate do they no longer have the information they have is no longer up to date? And it's about 18 to 24 months. 2 years after a clinician graduates, they already are behind in keeping up with the evidence base and the science in their specific field. Where I do think that that technology and analytics can be very helpful is bringing forward faster that knowledge from the evidence base to clinicians in ways that they don't have to go look up a journal and read it to find what is the right thing to do for their patients in the next, 10 months, let alone 10 years. So it's just, data is multiplying like crazy, and it's getting harder and harder to keep up with as a clinician, keep up with it all. And it shouldn't be our responsibility alone to have to do that. So I think there are ways in which we can use data responsibly and ethically and in right patient scenarios to drive that knowledge to the clinician, but also have the clinician use their critical thinking and their knowledge and their history and their experience to make that best decision for that patient.
Couldn't we just put Casey's data up on the screen and talk about it?
As to, let me speak to,
although, to be fair, the last time I tried it on Casey's chest, it didn't work.
Well, it only scanned for 2 years, and it was always more of a political statement than it was a utility. But yeah, this is the patient's level of frustration back in 2014 with, if I have to fill out this clipboard form one more time for you some bitches, I was here last week. It's the same form.
I'm really reminded by what Ines just said with the confirmation hearings we've just had, right? Or hopefully just finished now with future Justice Brown Jackson, which is the whole issue of, here is what the algorithm, i.e. the sentencing guideline says, and here is my ability to change it based on what my judgment as a judge, which apparently doesn't work in Missouri or wherever. Anyway, Ken,
So I was a long time on the health plan side, and I saw First there was case management, then care management, then disease management, then population management. And now we got all these 1,000-point solutions, digital health stuff aimed at particular people. And they all seem to be about, you try to figure out who the expensive people are going to be and then deter some ER visits or hospital stays. So I'm curious on whether, do you see that these have been distinct things, and or are we just getting better at marketing things?
Oh gosh, there's a lot. There's a lot of judgment there.
As I said, I was a long time on the health plan side.
These digital health companies got more money to market.
Yeah. So again, it's this like crawl, walk, run again, right? Like we started off in the healthcare industry, like any other industry that starts to use data, as like, oh, well, the problem is I don't have the data that I need, right? And, a lot of the solutions that you just talked about on the technology and analytics side, okay, well, then now they're providing data. Then the problem kind of changed to, well, I have the data, but I really don't know what to do with it. Like, tell me where to look to make and call it an opportunity. And I think there's a lot of companies out there that have made great strides towards that as well. I think we're in an area now where, and I'll say my opinion about where programs existed before versus where they can exist now, but we're in a state where we have the data. It's presented in a way that can be used responsibly, ethically, and with purpose. And now it's about identifying the opportunities from the bottom up. So whereas a lot of the technology and analytics tools that still exist today in the industry, they're looking at spend. Here's all the healthcare spend. And then we're going to say 10% of it, which is oftentimes arbitrary. We're going to take 10% and call it cost savings. And then we're going to throw it over the fence to the clinicians and say, clinicians, we think there's 10% of cost savings in this spend. Go find it. And the clinicians are like, goodness, like, I got to figure it out. I got to do all the hard math. I got to, give me some programs and services to help me. So outsprung these programs and services of care management, case management, team-based approach, multidisciplinary, all of which I think are still very relevant today, because I think it takes a multidisciplinary team to really impart good healthcare. But what's interesting about that is those programs, when they were set up initially, were, you throw a person at it that's trained in the healthcare space in a specific category of care, and they're just supposed to interview the patient and then know what to do. And I think where data and analytics is getting even more savvy, and again, we're probably still in that crawl to walk phase, is identifying and serving up for that clinician in that program, not only who the patients are that have opportunity to benefit from whatever the service is they're providing, but also what in the data identified them for that specific program or service. Then
you've mentioned many years of experience with a variety of different organizations. Looking back on it, thinking back on it, can you give a couple of examples where something that you worked on and created somehow ended up being gamed and used in the exact opposite way of what you had intended?
Yes. Oh my gosh. I have, unfortunately, a lot of these stories, learning moments. So I was working with a well-renowned healthcare and delivery system with a health plan, of which can go unnamed. You can look at my bio. You'll know who they are. I was working with a set of I was a medical director at the time. I was working with a set of medical directors at the time. We had at the time a hospital that was specialized in advanced pediatric care for high-risk pediatric patients. And what we were seeing is that there were a number of these pediatric patients that didn't have a primary care physician in the community, but mostly received the majority, if not all, of their care at this specialized hospital. Primary, specialty, ancillary, everything. And one of the strategies coming from the health plan side, very well intended, was to identify opportunities for cost savings by putting these children, connect them to a primary care physician in the community, and then having that primary care physician be the quarterback for all of their care and services, and potentially avoid some of the high cost services being provided at the specialty pediatric hospital. We set it up like a population health project. We identified a list of patients that could be potentially benefit from this service. We talked to the clinicians. We matched them with primary care providers in their community that were closer to where they lived. And then we monitored and tracked the outcomes and results for 2 years afterwards. What we were finding, we actually stopped the program early because what we found was for a third of the patients that actually worked brilliantly. We were able to reduce avoidable inpatient admissions, readmissions, and high cost care at the acute care hospital. We were able to they were better satisfied with their care in general and the quarterbacking of their care. And the patients' parents were really excited about having a local clinician that they could go to and call, and that was much, much closer than the facilities they were using before. For another third of the patients, no change. We weren't able to identify anything. But for a third of the patients, we actually identified that for a subset of the population, it just so happened to be that we're also in foster care, that adding that one more step of a primary care physician before they could go to the acute care hospital ended up being a statistically significant barrier to them receiving any care. And when we understood better what was happening in that population by interviewing the parents, we were able to see that oftentimes these children, for this subset of children in foster care, there were lots of other children that were in foster care that were being cared for by the same parent. So the parent had lots of different responsibilities, and it just so happens that now the care was fractioned, right? Where they were taking all the kids to this one hospital for all their care. Now this one child now had to go to a PCP in the neighborhood before they could go get other care. And so we actually stopped the program early because we said for that subset, this identification was not working. We actually ended up setting up a different set of services specialized for that specific subpopulation of pediatric patients, and then monitored their care and saw that they were getting consistent and better care over time. But that's one example of when you apply population health, if we weren't tracking the outcomes on that, if we just decided, oh, cost savings measure, let's put a PCP in place, hopes and dreams that everything will work out and patients will all be better off for it, we would have never have seen that subpopulation where we actually deterred care for them and where their outcomes were not good after a year or two, and even before then, because we stopped the program for that population.
So there's lots of potentially unintended consequences from all kinds of things, going back to the whole zip code area but down to the patient level.
Payers make those determinations all the time.
Yeah.
The January 1st, they'll just move all the cheese and, say, no, we have to do this, or we won't do that anymore, et cetera and so forth. And, and then people fall through the cracks, get sicker, and then, oh no, that's the patient's fault.
Well, I think there's a lot of good intentions out there. There's a lot of good science, good theory, good experience that's at play in all of these healthcare settings. The challenge is if we're not keeping track of it, if we're not looking to see what happens to the people that we're making these decisions on, we then can experience the results that we get.
So Ines, I'm going to ask you the hard question at the end, because this is the one.
Wait a minute, aren't all of these hard questions?
No, these are all easy. We get it. So the basic point, as you may have figured out, there are a lot of people in this panel who've on this show who've seen a lot of this stuff come and go over the years, and always going, why didn't we do that back in 1995 or 1985, whenever? We hear about value-based care. You're not on the one with Jeff Goldsmith and Morrison, who get very cynical about whether that stuff will ever happen, but they're frequent guests on this show as well. But we have better tools now than ever. I think we have to accept that, we have better tools. Companies doing that with budget for both, analytics and marketing and outreach, all that kind of good stuff. Is it, as they say in stock trading, this time, is it different? Are we actually going to move the needle? Or are we going to be back here in 25 years saying, well, we had this charming doctor on, and 10 years time, nothing much happened. We like Michael saying patient safety, nothing actually happened. What do you think?
Yeah, it's tough because there's a lot of really good ideas in history that have failed because of a really poor execution, right, and implementation. And my fear in the value-based care space for healthcare is that if every healthcare organization continues to only put a tiny percentage of their dollars spent or earned at risk and call it value-based and tell everybody in the world that they're doing value-based care, it's going to kill the movement. And what I've seen and worked with in hospitals is they say, oh, well, you know, we'll put the physician, 1% of the clinicians' compensation at risk. And then 99% of the rest is going to be fee for service. And then we're going to look and see how it does. And then we're going to call it good or not good. I'm sorry, but I follow the dollar. If you're not investing in this, if you're not doubling down in certain areas in this, don't say you're participating in value-based care, and please don't judge it as good or bad or neither, because there just isn't enough in there to warrant whether or not it's going to be successful. And my fear is that there's healthcare organizations across the country who are dabbling in this and not committing and not really understanding where they can be excellent and where they can improve, and that we're going to kill the whole idea because nobody really took it seriously or did enough to make a difference.
Now, one thing real quickly to second that, because I did some research on ACOs and recently looked at patient-centered care and ACOs. But the point is that when you see the data on ACOs succeeding or not, they tell you about the ACO, but what they never measure is the commitment of the organization. And so they compare—
or the readiness.
Because the academics think like this as opposed to in the real world, right? So they go, well, hospital versus doctor and blah, blah, blah. But the point is the doctor-run ones had a real commitment where their real dollars were at stake, whereas this huge health system had an ACO, but it was a small amount of their patients, and they're not going to discipline the doctors. And that level of commitment is not being measured often in what you see in these scholarly articles. And so you can give them the old, was it the bacon and eggs joke that for the chicken it's a contribution, but for the pig it's a total commitment? So that's what you can use to decide what we need for value-based care.
It's back to breakfast, as ever. Fantastic. All right, we are very close to the end. We've gone over a little bit over our hour, but let's do a quick go round and see what people are thinking about, either about this population health discussion, value-based care discussion, or whatever else is on their mind for the next week or so. I'll start with you, Casey.
Well, I'm attending my first big conference since the pandemic, going to DC the first few days of April, or the 3rd through the 5th of April.
Oh, it's Datapalooza?
Yeah, Datapalooza and the National Health Policy Conference, looking to see what signal is emerging from, if anybody is starting to make sense of, the trash fire that is data management in the U.S. healthcare system, and a lot of other places too, not just us. But I'll be looking for that, and then as usual on my privacy and transparency and hashtag FYPM data stump. So I'll be busy.
All right. That'll be fun. We'll look forward to you reporting back. I might even try to sneak out to that myself. Anyway, Mike.
Well, one of the things that went through my mind as I was listening is the question whether algorithms, which many times they're designed theoretically to promote simplicity, actually, by virtue of causing the people who would be negatively affected by them to game the system, actually end up creating more complexity.
That's an interesting point. And we had a similar discussion on with Jeff Goldsmith last week, and he was saying, the money doesn't matter. We have to establish professionalism. I don't know how you do that. I don't know how you stop people gaming the system. I mean, maybe the algorithms get very clever. I don't know. Or as I said, you may feature more. You have to feature the clinician a lot as well. But it's never simple, and there's always unintended consequences. But anyway, Kim, I'm sure you think this is all sorted out.
I'm not going to think about population health at all the next week or two. So the thing I'm watching is, as it turns out, both NIH and ARPA-H are without leaders at the moment. Right. So I'm going to be very curious to see whether the new people for those are going to be, the traditional establishment safe bets, or are going to bet down on the safe things, or whether somebody's going to take the chance to really put some people in there that are going to try different things, that are going to try to, get bigger risk or bigger outcomes.
Well, I didn't find out until last night. I was listening to NPR. We don't have an ambassador to Ukraine at the moment.
Yeah.
So, a lot of positions, even though we may have a Supreme Court justice, we may not have a lot of other stuff. Michael.
Big risks, and yet get through Senate confirmation, huh, Kim? Good luck on that. I'm looking at transparency. I'm looking at transparency on safety, radical transparency. How can we put out data that patients will pay attention to, as opposed to pseudo transparency where you put out more spreadsheets? I'm looking at transparency at some of the companies like Clarify that have algorithms that are not particularly transparent. And I think there's a balance between internal transparency, so people won't game it, and external transparency, so that you keep folks honest. And it's difficult. So trying to keep on, shine a bright light on what's happening and maybe cause some change. I've been wrongly optimistic about information for 25 years, but I do think that this time is going to be different because of outside companies coming in. Right? Because it's not the same old stakeholders who are trying to make sure that the doctor's pen, the drug companies are being very deferential to the docs because they need them. And of course, the health plans have learned, don't screw around, right? So I think the fact that you're bringing in these outside companies, you're bringing in people, even if you have physicians working there, I think we're changing the ecosystem and things will be better. Knock on wood.
All right. And as we'll give you the final word.
Well, I just want to say thank you for having me, and this was the most fun. And I will also say I won't be thinking about population health this next week either, because I'm going to be on a beach in Mexico trying not to get COVID.
Talk to Mike about that.
Actually, really thinking about that egg and bacon commitment analogy.
Well, that's fantastic. Well, I'm glad that you're going to go enjoy your vacation. Unlike Mike, we hope that unlike Mike, you get back in one piece rather than 27 pieces without making
Thousands,
airlines massively wealthier.
Are you telling me I might have to live in Mexico for a few months?
Well, that doesn't sound that bad. Mike, for some reason, decided he didn't want to take that option and came home. I don't know why. All right. With that, we have come definitely to the end of our time. I want to thank all of my guests. This was a lot of fun. We went slightly over time, but we really got into some deep topics here. This was THCB Gang for March 24th, 2022. This is Matthew Holt, your THCB founder and publisher, saying thanks for either watching or listening on the podcast later. My guests today were Michael Millenson from Chicago, Illinois, Casey Quinlan from Richmond, Virginia, capital of the Confederacy, Kim Bellard from Cincinnati, Mike Magee from the wilds of Connecticut. And Ines, I don't know where you live. Do you live in New York or do you live in San Francisco?
I live in Michigan and New Mexico.
Michigan and New Mexico. That's a strange place to live, but I understand there's some, isn't there one health plan that covers it all? I don't know. Anyway, Ines Maria Vigil, who is from Clarify Health Solutions, the author of Population Health Analytics, who was our guest this week. This is Matthew Holt saying thanks for listening. We will be back again next week with another different gang, and we're looking forward to hearing more from you over the next week or so. But with that, we are done for this episode of THCB Gang.